I would just like to say, before I hand it over to Teresa, that the League of Women Voters of the United States is a nonpartisan voter education organization that encouraging informed, active participation in government. It is the League's position that voting is a fundamental citizen right that must be guaranteed. Tonight's presentation will not necessarily represent the League, but is supportive of community members informing us about their work and various topics important to democracy. Teresa.
All right. Hi, everybody, and welcome. It's so good to see so many people here. This is such an important topic. I'm Teresa Reed. I'm a member of the Brews and Views Committee, and our topic tonight is Who Needs Medicare for All? But before we begin this timely program, I have a couple of announcements which will take a few minutes. The first announcement is just to keep you guys up to date about our intentions for the year. The program committee, which is chaired by the dynamo Donna Crutter, is working together to build a set of programs for the year that address specific themes each quarter. So all programs will be focused on, and all programs will be focused on League advocacy positions this year, which is exciting to me. The Lunch and Learn and Brews and Views programs will address different aspects of the same topic each month. At least that's our current intention. Partly to give us balance in the month, we've moved Brews and Views, as you might have noticed tonight, to the second Wednesday of the month, leaving Lunch and Learn on the fourth Friday. So the second and fourth weeks of every month, we have our major public programs. The first quarter of 2021, we're focusing on the all-important question of healthcare. Tonight, we have Medicare for All. Wednesday, February 10th, we'll be looking at how Washtenaw County is responding to the COVID-19 pandemic. And Wednesday, March 10th, we'll examine healthcare inequities, both in Washtenaw County and nationally. We plan to focus our second quarter on voting systems. On Wednesday, April 14th, we plan to address facts, myths, and fixes around voting system technology. On Wednesday, May 12th, we'll explore the impact of Prop 3 on redistricting in Michigan. And on Wednesday, June 9th, we'll look at the future of the Electoral College. This kind of quarterly planning is going to be going on throughout the year, so I'm excited about it. Donna's leadership has been super. So we have an exciting advocacy-focused year ahead. And then the second announcement is about an invitation from this league to all members to participate in forming a state-level league advocacy position on the uses and abuses of the lame duck legislative session. That's the period between the November elections and the seating of the newly elected representatives. As we know, we've had issues with that period in the past. Formal league advocacy positions are established through a bottom-up process. It's quite rigorous. A topic is selected in consultation with local leagues, and then local leagues study that topic with educational resources provided by the state league. The local organizations like us, the League of Women Voters of the Ann Arbor area, study the topic, make formal recommendations that are determined by consensus, and we send those up to the state league. Now, if the position being formulated is a national position, the state leagues will send those up, will compile them and send them all up to the National League. If it's a state position, the state league examines all the local recommendations and generates a state level advocacy position, which is what the lame duck position will be Michigan specific. So the league is soliciting your local member input on policies regarding legislation during lame duck sessions. Our position is due to the state board by March 31st. Lame duck study huddles, I love that phrase, study huddles will take place on 3 Saturday afternoons at 2-week intervals beginning in late January. And I want to say, don't feel like you have to write all this down. You should have an invitation in your email to participate in this. So 3 Saturday afternoons and at 2-week intervals starting January 30th. All of these meetings are from 3 to 5 p.m. So the study huddles on the lame duck session position, January 30th from 3 to 5, February 13th from 3 to 5, and February 27th from 3 to 5. Those are all Saturdays. We'll meet via Zoom to study background information and reach consensus on 9 questions that were provided by the Michigan League. So just wrapping up real quick, the scope of the lame duck study includes a review of the constitutional authority provided to the lame duck legislature in Michigan, the pros and cons of Michigan's lame duck process, a review of lame duck authority and process in other states, and possible future constraints to Michigan's lame duck session. It is work and it's really interesting and consequential. Again, the process is open to all league members. If you haven't received your invitation or want more information, you can mail program@lwvannarbor.org, as in League of Women Voters Annarbor.org, program@lwvannarbor.org. If you're not a member and you want to participate in the lame duck study, you can join the league at lwvannarbor.org. The cost for joining is $70, which is divided among local, state, and national leagues. We're recording now, right? Anybody say if we're not? Tech team. Okay. All right. Now, finally, without further ado, we can pivot to tonight's program, which I'm so excited about. Who needs Medicare for all? Many Democratic lawmakers have proposed a variety of solutions for America's healthcare crisis. Good sense of what that might be, but many of us are unclear about the real costs of Medicare for all, how it would be paid for, how it would work, and how it compares with other healthcare plans being proposed, including by President-elect Joe Biden. Professor Eli Rubin of Western Michigan University, president of the nonprofit Michigan for Single Payer Healthcare, is joining us tonight to answer these and other questions you have about how best to remedy America's glaring failure to provide affordable healthcare for all citizens. Dr. Rubin?
Thank you so much, Teresa, and thank you, everybody. Thank you to the League for inviting me. The work that the League does is so important. I talk to my students, I get to have them on election day and remind them to go vote because we're studying the history of countries that, the Nazi Germany or the USSR, and we get to look firsthand at what happens when people lose their right to vote, and it's not a pretty picture. It never is. The right to vote is really the thing that keeps us from going down those paths. So, I'm really excited to be here, and I'm really honored because this is a great organization. So I am going to put up my slideshow here. Oops, before I do, I need to share my screen. There, that should work. And so I will go there. Okay, are we good? Everybody can see that? Okay, great. So, as Teresa said, I am the president of a nonprofit group called Michigan for Single Payer Healthcare, and we are a grassroots, all-volunteer group of folks who are motivated in part by the sentiment that Martin Luther King expressed a long time ago, and when he said injustice in healthcare is the most shocking and inhumane. And we have seen that played out in tragic forms in this pandemic, in which the death toll has been way higher than it needed to be, in part because of terrible healthcare discrepancies in our communities, especially in lower income and Black and brown communities. And our vision could be simply summed up as we want to live in a country where everybody can get the care that they need, regardless of how much money they have or don't have, that it's their right. And so that is our North Star, our goal. And we feel that Medicare for All is the best way to get there. And so before jumping into the details about Medicare for All, and we're going to get into a lot of details, I want to outline the problem. And I think some people have, a sense of the problem but I want to spell it out for you guys. Um, Number one is simply that as a country, we spend way more than all our other peer countries, what we call the OECD or industrialized countries like France, Britain, Korea, um, Switzerland, places like that. We spend a lot more per capita on healthcare, especially in terms of out of pocket private spending. However, we get very little back for that spending. In other words, we have an incredibly inefficient system. We spend a lot of money, but all our statistics show that our health is way worse than all our peer countries. When we are compared to Germany, the UK, Canada, France, Italy, their life expectancies are higher than ours. Our infant mortality is way higher than theirs. Our maternal mortality in particular is really atrocious. When you look at Canada, which is on the same continent as us, and we have 5 times as many mothers die in childbirth. And if you then rerun these statistics, selecting for race, and ethnicity, it gets even worse. It looks even worse than this. There's a real crisis of maternal mortality among African American and Latina women. And so for all the money we're spending, we're not getting anything back for it. And you can combine these two statistics in terms of how good our healthcare system is overall, just measured by all these different measurements, all these different metrics, and then how much we spend, and you can see what an outlier we are. Most of the industrialized world is about here, and you can see where we are. It's not good, not a good place to be. In fact, of the industrialized countries in the world, we are the only one that doesn't guarantee healthcare of some kind. As we can talk about maybe more in the question and answer, there are many different models out there. Switzerland's system is different than Australia's, which is different than Japan's, which is different than Great Britain's. But they all, at the end of the day, if you live there and you're a citizen of Australia or South Korea or Great Britain or France, you can never be without healthcare. You can't ever be in a situation where you can't actually get help for your problem because you don't have enough money. And it's not just the OECD nations, the Frances and the Italys and the Australias. Most of South America guarantees universal health care free of cost at the point of service. And that's a term I'm going to use a lot, at the point of service. None of this is free. Doctors, nurses have to be paid, medicines have to be paid for, so on and so forth. But the question is, do you have to fork over a big wad of cash at the moment that you need to get open heart surgery, or do you get a bill, right afterwards or not? You'll see not in Brazil, not in Argentina, not in Russia, not in Saudi Arabia, not in Algeria, not in Mexico, not in Kazakhstan, only here, and then the most sort of, impoverished third world African nations. Those are our peers when it comes to this. And so, of course, we did pass the ACA, and it was a decades-long struggle. It came with a huge political cost for Democrats, and as I was saying to the league, to the organizers of tonight's panel, one of the ways that I got involved in this fight was originally to stop Republicans from tearing down the ACA, because it was a good first step. But it's not a complete step. Despite the ACA, there are still 30 million Americans who are uninsured, about the same number as there were before the ACA. What has happened is that the ACA has directly helped a number of people, but the problems that prompted the ACA have gotten worse and worse and worse. So it's almost like one step forward and one step back. And just to fill out, what that problem looks like some more, what it means when you have 30 million people in your country who don't have health insurance, that leads to Harvard. The Harvard study suggests 45,000 people a year dying as a direct result. There are probably indirect results that are harder to trace, such as suicides over the depression of being bankrupted by medical bills. But this is a direct result. But another really important thing to consider, along with the uninsured, is what we call the underinsured. So people can sometimes get insurance either through their employer or buying it directly, privately, or on Obamacare exchanges. But because there's so many out-of-pocket costs built in, and I'm sure you're all aware of these, none of us like to fork over the copays, the premiums, the deductibles. It's all very confusing. What's the difference between an individual deductible and a family deductible and a this and a that? And some of them are very, very high to the point where, you know, if your deductible is $2 or $3 or $4 or $5,000 and you only have $500 in the bank, you still can't go to the doctor even though you have insurance, right? And that's a little bit of an outlier, but deductibles, you know, again, this is the amount of money you have to pay out of pocket before your insurance kicks in, have skyrocketed. So, and you can see here, the average deductible is now $1,350, and that has skyrocketed since 2008. And it's one of the ways in which private insurance companies continue to make profits, even though the Obamacare law requires them to insure people who have pre-existing conditions, who they consider to be more expensive than healthy people. And you can see that this is a problem because it hasn't kept up with inflation, and it hasn't kept up with earnings, which are barely ahead of inflation. And again, you know, all of us have a different sort of idea of like what the value of a dollar is. But to give you an idea, for most Americans, 61% say they could not cover an unexpected medical bill in the amount of $1,000. Right. So if your deductible is $1,350 and and that's average, you could do the math. A lot of people, even with insurance, if they had to be rushed to the hospital or something like that, they couldn't cover the bill that they would get. And then, of course, the other part of the equation, guys, is premiums. It's not just the deductibles, it's the amount you pay every month, regardless of whether you need to use your insurance or not. And that also has skyrocketed. You can see, and most people get their insurance in this country from work. And so there's always an employer contribution and a worker contribution. And usually the employer contribution is the lion's share. So it's like, you know, 2/3 or 3/5. And you can see in 2008 that the total cost for a family plan, when you add together what the company pays for and what you out of pocket pay for, it's $1,200. It's now $12,000. It's now $19,000, almost $20,000. Again, that's average. So there are some people, some companies that have not very good deals, and they get really, really screwed over. But you can again see just how much premiums have also increased. And lest anybody say, well, that's increased, but wages have also gone up. Inflation has kept pace. They haven't, and you can see that right here. Obamacare probably helped to slow the gap. So before Obamacare, it was really, really out of control, in which the premium increases far outstripped what people were getting as far as raises to keep up with that. It's slowed down a little bit, but it's still really out of whack. People, every year, that means they fall further and further behind financially, because the amount that their salary or pay might go up doesn't come close to matching the amount that their premiums go up. So every year there's just more and more money that's flowing out of their family budget, and that means less for them. And again, just to give you some kind of reference point, the median income in Michigan is about $55,000 a year. That's for a household, so not for an individual. And so that means that's median, not average. So that means half of all the people earning money, households earning money in our state, make less than that, less. And it's always really shocking to me, because it's not very much money to live on. And you consider half the people in our state make less than that. That's concerning. And then when you add these incredibly increasing costs on top of that 55,000, you can see how people's disposable income is being completely drained away from them. Some more national statistics to throw at you. Of all the bankruptcies that happen in this country, about 2/3 of them are purely because of medical bills. And it's probably more than that too, because a lot of bankruptcies that look like people maxing out their credit cards and being profligate spenders is actually people maxing out their credit cards to pay their medical bills, or maxing out their credit cards to buy groceries because all their available cash is going to pay medical bills. So it's probably more than this. And that's about 1 million Americans a year are going bankrupt that we can definitively say due to medical bills. That's a lot. 25% of all Americans struggle to pay their medical bills. That means they have to get on a payment plan with sometimes ruinous interest rates. They have to borrow money, they have to sell something, they have to sell their car, sell their house to pay their medical bills. And this includes 20% of those who have insurance. This is the point I was making about underinsurance, right? People, it's not just like you get insurance and you're set. You get insurance and you're still in danger of falling into poverty and falling into financial ruin. And the thing to really emphasize here is this doesn't happen. Right across the border in Canada, this is unknown. There are other reasons people go bankrupt in Canada. There are other reasons people go bankrupt in Australia and Brazil and Germany and so on and so forth. But it's not medical bills that's causing it. And one of the really concerning statistics is what happens to people with cancer. Because, and we'll talk about this in a second, but people with cancer, because it's both it's a blessing and a curse that we've developed so many new medicines and procedures and techniques and technologies to treat people with cancer, whereas maybe a couple generations ago people would get a diagnosis and then that's it, that's curtains, there's nothing to be done. Now we can keep people alive, we can save their lives, but this is very expensive. These cancer treatments go on for a long time, they can be very expensive. And insurance companies hate to pay those costs. So people constantly are getting rejections while they're trying to fight for their lives. They don't have the power to the energy to fight against insurance companies while they're suffering through chemotherapy or radiation therapy. And what ends up happening to 42% of them is that within 2 years of their diagnosis, they have to sell everything that they own to pay their bills. And they end up destitute, even if they survive the cancer. And more people thankfully are. They survive, but with very little of a life to return to. You can see this on the popular fundraising site GoFundMe. The single largest category on GoFundMe is medical debt. It accounts for about $1.5 billion. And you know, the CEO of GoFundMe recently came out a year and a half ago and addressed this and said GoFundMe was never ever intended to be an alternative medical insurance system. It was supposed to be, you know, raise money for a new playground or, you know, something like that. And you know, you can go on GoFundMe and you can look, and there are a lot of people like this guy Shane Boyle, who was diabetic, didn't have insurance and couldn't afford his insulin. $750 a month, and he couldn't afford it. So he went on GoFundMe, and this month he did well. This was created in February. I think this was a little bit later in 2017. But you know, one of the things, as you guys know about GoFundMe's, is, you know, initially a lot of people, it's viral, people are sharing it on social media, they're donating, you know, and it's great. But after a while, it sort of fades from people's social media feeds, and then they kind of forget about you. And this is something where he needed $750 every month. And eventually the money kind of ran out and he went into a diabetic coma and he died. This guy died. And there are many, many others like him who have died. And, you know, again, I mentioned this. So, you know, one of the things that happens is that insurance companies deny claims, right? You go to the doctor, you have a procedure done. That procedure, the doctor bills to your insurance company. Pay me $5,000 for, you know, this, and this. The insurance company then sometimes will say, no, we'll give you $1,500. We're not paying for the other $3,500. And then it's left either for the doctor to pick up the phone and fight with them and sit on hold all day when he's supposed to be seeing patients, or it's for them to say, I'm not even going to deal with the insurance company. This is your problem, patient. I'm going to send you the bill for the $350 or $3,500. So something like that, right? These denials happen. Then it's up to you to spend all day on hold on the phone with the insurance companies and try to get them to cover the rest of the money. And they do this about 20% of the time. Some companies are worse and some companies are better. But the average is about 20% of the time. And it's a formula that many of them use. They have a quota. If you're working at the company, you're supposed to reject 1/5 of the claims that come through. If you don't, you get in trouble at the company. If you do, you get promoted. And they reject a number, and of course there's always some scurrilous claims, and there's always some unethical doctors who bill for things, $5,000 for a Band-Aid and see if they could get the insurance company, catch them not paying attention and get them to send them a check for $5,000 for a Band-Aid. But the reality is most doctors are not like that. The insurance companies simply sometimes at random pick out, things, every other item on the bill to reject. And the reason they do that is because they know that most people, when their claim is rejected, will think it's their fault, will think it's, it's what fate has in store for them, and won't fight back or don't have the energy to, again, if they're sick or if they're injured. And we know that 60 to 80% of these denials are overturned on appeal. So if you ever get, and this may have happened to some of you guys, if you ever get one of these bills where you thought you were covered and you thought everything was paid for, and then all of a sudden a big, big bill comes in the mail, and you're like, what the heck? I thought this was going to be, why do I have insurance if I'm getting bills that I have to personally pay? If you call them up and you appeal, you have a 60 to 80% chance of getting it overturned, and they'll cover the bill. And the reason they do that is because they know that a certain number of people, a majority, won't even try to appeal, don't even know that they can appeal, wouldn't even know how to go about doing it. And so this is where they make their profit margins. And this is what insurance denials look like. You get a bill that says pay this amount. That's not $1,070. That's not $10,700. That's $107,000. That's a bill. You have 1 month to pay it. You can pay by Visa, MasterCard, or Discover, right? And so, people's choices, pay for it and go broke, don't pay for it, don't go broke, and live in chronic pain, live with a deteriorating condition that could eventually kill you, not be able to work, or not have any good quality of life. And there has been some work done, in Washington about surprise billing, and that has helped some of this. But the fundamental issue still remains that insurance companies will look for denials, and they can't do denials. If they don't do denials, they can't make their profit margins. So you continue to hear these stories about kids who's this is a story about a young family with a young child who bumped her head, and it's on a table, and it's swelled up a little bit. And a lot of times, if you've been in this position with your kids or even grandkids or nephews or nieces, and you call after hours, they send you to an on-call nurse. And the on-call nurse almost always says, you should go to the emergency room, even if it's really not necessary. And that has to do with liability issues. They would much rather tell you to go to the emergency room and be wrong, and it turns out to be nothing, than tell you don't need to go to the emergency room and it is something and a kid dies or something like that. So she bumps her head, they go to the emergency room, gets a children's Tylenol and an ice pack and concussion test, and it comes back negative. It's okay. It's just a regular bump on the head. And then they get a bill for thousands and thousands of dollars. And you would ask, well, why in the world would that happen? And it's because the emergency room, the hospital, is constantly getting stiffed by other people who don't have insurance or means to pay. So they overcharge other patients, and they see if the insurance company will be dumb enough to pay them $12,000 for a children's Tylenol and an ice pack. And when they're not, they send you the bill for $12,000, and you never know when that's going to happen. And, I think the thing to keep in mind is that the financial cost of healthcare leads to some really horrible decisions. When Obamacare was being debated, there was a lie passed around about death panels. But the reality is we do have death panels. They're just sort of a panel of one, because you're often forced to decide whether or not the cost of your care, of saving your life, is worth bankrupting your entire family, ruining your children's lives, draining their college funds, selling your house, selling all your assets, everything you've worked so hard for. So you can see, this person's father had Parkinson's, so he killed himself because he didn't want to take away all their, drain their, his family's, his kids' money. Same thing. This guy died of uh, um, of cancer after having seen a friend um, uh, drain his family's entire financial future to fight lymphoma and die anyway, and then leave his family in poverty. This person's father got a cancer diagnosis and just simply refused treatment and went off and died on his own because he didn't want to do that to his family. And this is from a Twitter thread from last year that went on for thousands and thousands of posts like this. This is just four that I picked out at random. You can go back and look it up on Twitter if you're good at that kind of thing. It's thousands and thousands of examples like this. So our basic point, and some people may object to this, and that's understandable, we can have a debate about that, is that health insurance shouldn't really exist as a private business. Certainly not as the main model that we use to deliver healthcare in this country, because they are a business and they are looking for profits. And even if they are technically nonprofits, they still can, that only means they don't have to pay off shareholders. They're still looking for more money to grow and get new headquarters and get new, bigger salaries for their staff. Nonprofit doesn't mean you give away all the money that you make. And that's because the business model fundamentally doesn't make sense. It makes sense to have auto insurance, because the idea of insurance, obviously, as you guys know, is you put in, everybody throws in money into a central pot. And then if one of us, one person in that group has a problem, then they can take some of the money out, and you don't know who it's going to be. Most people don't get into car accidents, at least not serious car accidents. The same is true of homeowners insurance. Most people don't have fires burn down their homes, or lightning strike their homes, or tornadoes or floods destroy their homes. That's a pretty rare event. So homeowners insurance works as a model because most of the people putting money in are not going to need to take money out. But health is different, because we're not cars, we're not homes, we're people, we're bodies, and almost all of us are going to need to have medical care at some point in our lives. It's a rare person who goes through their entire life never needing to see a doctor and then dies, and there's no medical costs ever associated with their life. So we have now a situation with healthcare where everybody has to draw out from that pool. And so it's not profitable. And so that's really the problem that we're dealing with. There's another issue here, and we're going to start comparing this to Medicare. Medicare, which is a government program, and people, oftentimes have this myth that if it's a government program, it must be inefficient, spends about 2% of its total budget on administration. That means, people who are not doctors, people who are not nurses, right? People who are administrators, people who are doing paperwork, who are doing records, who are doing billing. Private health insurance companies spend 31% of their revenue on administration. And there's a lot of reasons for that, but part of it's just simply the scale. And part of it is that each individual company has its own way of doing things, and that makes it very hard to interact with all these other doctors and all these other providers. But part of it's also that the administrator of Medicare is a government bureaucrat, and government bureaucrats don't make that much money. Whereas the CEO of these insurance companies make an enormous amount of money. The CEO of United Health makes $83 million a year. Blue Cross Blue Shield, the CEO in Michigan, makes $19 million a year. And so, that doesn't account for, all the money, but it gives you an idea of all the executives below them who are also making tens of millions of dollars, or at least hundreds and hundreds of thousands of dollars. And they are, you know, it's one reason why the premiums and stuff are so high. And then you have the impact on doctors, and how they deal with insurance companies. If you talk to just about any doctor, they will tell you the hardest part of their jobs is probably telling, patients that bad news about their health, like really bad news, sad news. But the second hardest part of their job is dealing with insurance companies, and it's a narrow second. They spend 1/3 of their time / revenue or income dealing with insurance companies. As I mentioned before, some of them just completely give up on it. Some providers just say, you know what, I'm not going to take insurance. I'm only going to take patients who can pay out of pocket. Others have to employ office staffs full of people whose job it is all day long is to fight with insurance companies for the denial so that they can get back some of the money they've already expended treating patients. And you see the results of this in real time. This is, in Appalachia, which is the poorest part of our country. The health outcomes are atrocious, frankly. And there are a lot of reasons for that, but one of the reasons is the poverty is linked to the lack of health insurance, and including dental insurance. People talk about Mountain Dew mouth as a way, and actually you'll see that here, as a way of, if you've read the book or seen the movie Hillbilly Elegy, of shaming poor people who live in Appalachia. But the other part of the fact that so many people's teeth are falling out in places like Kentucky or Southern Ohio is simply they don't have insurance. They've never been to a dentist. And the only chance is to go to these free clinics that doctors and dentists come around to rural areas, and people camp out for days just to get an abscessed tooth taken out or a lump in their breast looked at, because they have no other way of getting it done. So those are the problems, and let's talk about the solution. Medicare for all. Technically, we use the term improved and expanded Medicare for all, and right away we have a little bit of an issue, because Medicare, people will often say when they hear about the proposal for Medicare for all, they'll say, I'm on Medicare and it's okay, but you should be aware that you still have to pay out of pocket. And there's still copays, there's still, stuff, and it doesn't cover dental, and it doesn't cover vision, it doesn't cover hearing aids. So, it's not like this great panacea. So what we're supporting and what has been proposed is what's called technically improved and expanded Medicare for all. So it's like Medicare, but better and for everybody. So it's not just that everybody's in, it's that the thing itself is better. And so we'll go over that. Now, there's 3 things that we want to focus on. I won't talk as much about this down below, but I can talk about it in the question and answer. In the U.S. House, Representative Pramila Jayapal, who represents Seattle, Washington, has introduced what's called HR 1384. Now, at each Congress, they have to kind of revise these bills, and they give them new numbers. So these numbers will change, but this is what people will know what you're referring to if you write to a congressperson or something. And then Bernie Sanders introduced Senate Bill 1804, which is a very similar version of this. In the Michigan House of Representatives, Yusuf Rabi from Ann Arbor introduced House Bill 6285. That too will get a new number, but it's a proposal for a kind of single payer that would just be for Michiganders, called MI Care or My Care. And so let's look at the basic idea of how it works. This is one of the questions Teresa put out there. So first, everybody would be automatically enrolled. There wouldn't be any enrollment period. If you miss the enrollment period in October, you have to wait a year, anything like that. Every single man, woman, and child in this country would get a card from Medicare, and it would entitle them to be part of Medicare. They wouldn't have to do anything. And that's important because for Medicare, but also for other what we call single payer programs like Medicaid, there's eligibility. You have to apply for it. And the application process can be confusing. It can be difficult. Oftentimes overworked government bureaucrats make mistakes and lose your application. And then there's a whole other subset of sad stories about people who applied for Medicaid, but didn't get it because they filled out one line of the form wrong or something, and then they had something terrible happen, but they didn't have their Medicaid and they were ruined. So this is really important. Everybody gets it automatically. You don't have to do anything. Second thing that's really, really important, no out-of-pocket costs. Again, that doesn't mean that nobody's paying for it. It means that you personally don't have to fork over your cash that's in your bank account or use your credit card to pay anything related to your healthcare. You don't need to worry about what anything will cost. If your child has a fever that won't break, you take them to the doctor and you worry about the fever. If you have, if you wrench your ankle playing, soccer or something and the swelling won't go down and you're really getting worried about it, you should worry about your ankle. You should not be thinking about money. If you find a lump in your, in your breast or something like that, you should be laser focused on what is going on with that lump, not what is going on with the lump and also how much is this going to cost. So that's the two really key things. The expanded part, so that's part of the expanded part, right? It would do away with premiums and copays. And then it would also expand the coverage. So it would be what Medicare covers now, but it would also cover vision, it would cover dental, and it would cover hearing aids. And it would cover long-term elder and disability care. So if you are if you need assistance in your home, or if you're caring for a relative who's disabled, you would get care for that. And like Medicaid, it would, but not necessarily other programs, it would also cover transportation, because in inner cities and in poor rural areas like you saw in Appalachia, one of the big problems isn't just getting people coverage. They even if they get insurance, it's a 2.5-hour ride, to the nearest hospital or medical provider, or they don't have a car and there's no good public transportation, or they're not physically able to take public transportation. These are all the people who keep falling through the cracks of our healthcare system, and they're many of the people who have been disproportionately badly hit by COVID. And then, of course, there's always the concern about big government programs that people will bilk them, right? You just start, billing them for this and billing them for that, and just, feeding at the trough of Uncle Sam and committing billing fraud. So, or quasi fraud, inflated rates. So reimbursement rates, right? So when a hospital does a procedure and then they bill Medicare and Medicare pays them for their costs, is at Medicare rates. And Medicare rates are less than private insurance rates. And some people who are opposed to this will say that hospitals will go under if you do this, because the Medicare and Medicaid patients bring in a lot less money relative to the Aetna and Blue Cross Blue Shield patients. If you're running a hospital, you wanna have more Blue Cross Blue Shield or Aetna or Cigna patients than you do Medicare or Medicaid patients. If you have too many Medicare and Medicaid patients, your hospital's going to go under, right? They need that much bigger reimbursement rate from the private insurance companies to offset the money they feel they're not getting from Medicare. However, we feel like this is not true, that there are other elements of this, and I can go into why that is. It has to do mainly with emergency rooms and how so many people in this country use the emergency room as their primary and secondary provider. If they've got sniffles, if they've got, anything, they can't see a doctor, so they just go to the emergency room because they can get treated for free. And that comes out of the hospital's budget. And so if people start showing up in the emergency room and they've all got a Medicare card, that offsets the loss of the private insurance. The GI bill in the House does something called global budgeting. And that's basically like an allowance. You give a hospital an allowance. You say, hey, $250 million for this calendar year. You can reimburse us up to $250 million. After that, you are on your own. The government is not going to reimburse your costs. If you hit 250 million or 500 million or whatever it is by October, we're not going to give you more money after that. Then you're just going to have to dip into your own reserves to pay your own bills. And the reason they do that is it helps give an incentive to hospitals to not spend money on things like beautiful atriums. And, I mean, this is, having lived in Kalamazoo, for a while and going to the, admittedly very good hospital, Bronson Hospital in Kalamazoo. The atrium is beautiful. The grand piano and the guy playing the grand piano and these waterfalls and this, the trees and these, art installations. Is that really what the money that's flowing from us through our insurance companies should be paying for? Or should they be paying for cancer treatment? Should they be paying for fixing broken bones? It also allows Medicare to negotiate with pharmaceutical companies, which it currently can't do. And there's an enormous amount that Medicare can do to lower drug prices if it could, especially if it represented all Americans. Pharmaceutical companies would have no choice but to agree to their prices for things like insulin or cancer medicine. A couple other things about this bill. And this is where we get into the controversial stuff. And some people may get up to this point and agree, and then after this point say, no, I don't agree with that part of it. The bills don't allow for duplication of service, meaning there can still be private health insurance companies, but they cannot offer the same things as Medicare. They can't compete against Medicare. They can offer supplemental plans. For example, Medicare might offer you 6 chiropractic visits a year. So if you have a bad back and you need to go to your chiropractor at least once a month, you're probably going to need a supplemental plan that includes an additional 6 months or more visits to chiropractors. So you would buy that on top of the Medicare for all. But you couldn't just have Aetna or Blue Cross competing against the US government. And so, of course, that would mean that most of these humongous private health insurance companies would go away, or they would shrink dramatically. And that would mean a lot of people would lose their jobs. It's estimated several 100,000 people would probably lose their jobs. So these bills offer first of all, a phase-in period. So it's not all happening at once. In the House bill, it's a 2-year phase-in. In the Senate bill, it's a 4-year phase-in. And the Jayapal bill offers 2 years. The Sanders bill offers 5 years of salary replacement for displaced workers, people who lose their job, and preferential hiring, because as Medicare expands, it's going to need a lot of the same people with the same skill sets like billing and coding to be rehired. Only instead of working for Blue Cross Blue Shield, they'll now be working for the United States. And then we get to the question that Teresa also raised. How are you going to pay for all this? And this is one of the least understood issues, even among people who are in favor of Medicare for all. And this, we really get into the weeds. And so I'm going to get into the weeds. And if you miss stuff, I think Teresa has a copy of this that she can make available to you, of this slideshow. But I'm also happy to go over it again in the question and answer. So the best way to think about this is, as a country, all added up, we spend about $3 trillion on healthcare. It's actually a little bit more now, $3 trillion, but let's say around $3 trillion on healthcare. Okay, that's everything. That's what Medicare spends, Medicaid spends. That's what is spent by Blue Cross Blue Shield. It's what's spent by just out of pocket. Every dollar that gets spent on healthcare, it adds up to $3 trillion in this country. Now, the first thing is 60% of that $3 trillion, it's already single payer. Here's what nobody will tell you. We are already almost 2/3 of the way to being a single payer country. That's how many people are on Medicaid, Medicare, and several other programs that are single payer, meaning there's one organization and it's a taxpayer funded organization that pays your medical bills. Also included in this is the Veterans Administration, the what's called TRICARE for active duty military, what's called S-CHIP for children, even the Indian Health Bureau. So the Native American has their own sort of single payer form of healthcare. Okay, so 60% is already single payer. That's about 1.9 trillion a year. Okay, so we need to replace the spending that's not coming from the government, that is going from employers to health insurance companies, it's about 1.12 trillion, right? Or sometimes they like to do this over 10 years. So they'll say 11.2 trillion over 10 years. That's a lot of money. We need to find that, right? Where are we going to get that from? Here's the thing. We don't need to find new money. We don't need to find new money. We are already spending that money. That's the money that we collectively spend every month when our premiums go to our premium payments go to the health insurance companies, when we go to the doctor and have to pay 30 or 40 or 50 bucks for our copay. All of that, that's the money that we're already spending. I like to put this in big, bold red letters. We are already spending this money. It's not new money. It's not like we're going to have to find new sources of money on top of what we're already spending. The way this will work is you will no longer spend money on your copays. You will no longer spend money on your premiums or your deductibles. Instead, some of that spending will, instead of going to Blue Cross Blue Shield or Aetna, instead it will just go to Uncle Sam. We can come back to this. Sometimes people just have trouble wrapping their mind around this idea. So the ways that have been proposed to do this is first of all, we can save about $500 billion a year out of or over 10 years, sorry, just simply through the efficiency savings, the cost reduction and efficiency savings that will happen by eliminating this hodgepodge of all these different insurance companies and payers, and that 31% of administrative overhead versus the 2% of Medicare. That saves you, that you got 500 billion right there. And then what's been proposed is a 4.5%, or actually in some other versions, just a 4% household premium of all households that make over 29,000 in income. And so over 10 years, that would net the government 3.5 trillion. Remember, we're trying to get up to 11.2 trillion. But here's the thing, because what you're doing is erasing all the private health insurance costs, erasing the deductibles, erasing the premiums, erasing the copays, and replacing it with a 4.5%, most households will save money. Our household is, definitely up there, in terms of the income bracket, about around 90th percentile probably. And so, I ran these calculations for us. And this would not save us $4,000 a year, but then again, we don't really need it. It would save us probably more like $500 or $1,000 a year. 1,200. One calculation we did would save us about $1,200 a year. But the further down you go the income scale, the more the savings are, until you get down to to the median, 55,000. Okay, we're getting deep into the weeds here, so if people miss something, it's fine. We can go back over it. Then there would be a 7.5% income tax on employers after their first $2 million in earnings. So you can earn $2 million for your business, and then after that, you get a 7.5% on earnings after that. So small businesses will be largely spared. They won't have to worry about this at all. It's usually those bigger businesses that are making more than $2 million a year that are the ones that are providing healthcare to their health insurance to their employees, and they are getting squeezed tremendously. So this will net 3.9 trillion, and it will save most employers money unless they're not currently offering their employees any benefits. But in that case, it's something they should have been doing all along. So some will complain, but this is what they should have been doing. Those who have been doing right by their employees and offering them health benefits will save a lot of money. We're talking about 7.5%. I personally know several business owners, small business owners, that are paying 20, 25, 27% of their total budget on employee healthcare costs. There doesn't quite get us to 11.2 trillion, so there's some other options that can be picked and chosen from. There's a lot of tax loopholes that you can close. Employers get a tax break on the health insurance payments that they make, so you don't need that anymore. So that gets you 4.2 trillion over 10 years. You can raise the top marginal tax rates. You can get 1.8 trillion out of that. You could have a 1% wealth tax. That gives you 1.3 trillion. And so all of this adds up to more than enough to pay for it, frankly. We don't need all of that stuff. I'm getting close to the end. I'm going to try to wrap up in the next 5 to 6 minutes. You know, a lot of times people will say we can't afford a single payer Medicare for all. Our answer is we can't actually, we can't afford not to have it. Again, if we do nothing, these costs will continue to grow and grow out of control. We'll be spending as a country $6 trillion by 2027. So Medicare for All saves our country money, and it saves us personally money. And again, those at the very top of the income spectrum, you know, will probably not save money, but then again, they don't really need it. Again, this is going to save our country between 2 and 5 trillion. The 2 trillion is an estimate from a conservative think tank. 5 trillion is from a very liberal think tank. You want to split the difference? Fine. $3.5 trillion is still an enormous amount of money that it would allow us to fix every road and bridge in this country and send every American who wanted to go to college for a long time. Okay, so I'm going to kind of go through, because some of this we can address in the questions, and I don't want to go too long. But the question is how it will get passed. Obviously, we needed to take the House, the Senate, and the presidency. By we, I mean Democrats. I know this is a nonpartisan, so I should clarify that. So, but Democrats are the only ones who are going to do this. So they've done it. And then, of course, you need 60 votes to get over the filibuster threshold, but we're very in favor of ending the filibuster. This is that important. And then you can also, what Bernie Sanders has said he prefers doing, not ending the filibuster, you can use what's called reconciliation, where you only need 51 votes to do that. And the support is there as of 2019, and we don't know how the pandemic is going to affect all of this. But even before the pandemic, 85% of Democrats, 70% of independents, 52% of Republicans even supported Medicare for all. And so I just want to go through some of the pros really quickly, and then we'll be done. Just to imagine what life will be like with with Medicare for all. So the first thing that would happen is that every provider would be in network. You would never have to worry if you were on vacation or traveling in another state or out of town, that in an emergency, the doctor or the hospital that you go to would be out of network and thus not covered. There would be simply coverage everywhere you go. Unions would have a much easier time of it. And I know there are some people in unions who object to this, and we can talk about that in a second. But I'm in a union, and I know every time we have to negotiate a contract, the same thing happens. Do you want a raise? Do you want your healthcare premiums to go up? We're always forced to make this impossible choice between wages and healthcare costs. We know that after the age of 65, entrepreneurship actually skyrockets because people are on Medicare, and having your healthcare squared away allows you to leave a big company that you maybe don't want to work at, that you're only at for the benefits, to be able to start. So we would expect to see a blossoming of new businesses. And frankly, one of the really overlooked reasons as to why people stay in abusive relationships is they need the benefits, they need the health care. And it would also reduce our auto insurance rates. One estimate has up to 60%. Some people disagree with that, but it would definitely reduce our auto insurance because auto insurance gets used as health insurance. And frankly, health insurance is baked into all these other forms of liability insurance: malpractice, workers' comp, general liability, business liability, homeowners insurance. It's all there to pay somebody's medical bills. None of that would be necessary. Ambulance chasing would come to an end. And frankly, working at a university, I can tell you one of the reasons tuition keeps going up every single year, putting more and more students into debt. It's not my salary. I'm not getting very many raises. It's the healthcare costs of all the employees. And so this is baked into all kinds of things. And perhaps most importantly, doctors can go back to focusing on medicine again and not spending all their time fighting with insurance companies. And frankly, if you lose your job, as so many people have done in this last year, it's not a catastrophe, at least not in terms of your health care. So I'm going to actually, I think in the interest of time, I'm going to skip over some of these other plans. I'm just going to show them to you really quickly, and then we can go back to them if there are questions about them. So there are other proposals. One from Debbie Stabenow is to simply lower the age that you can buy into Medicare to 50. The other is Joe Biden's plan that he ran on, which is a public option that you can buy into. Another more ambitious plan from the Center for American Progress, a liberal think tank called Medicare for America, is very close to Medicare for all, but it doesn't ban private health insurance companies. It leaves them to compete against Medicare. And so, you know, I end with this quote from the healthcare activist and sufferer of ALS, Addie Barkan, who says that, you know, any of these plans that leave any kind of financial barrier to care, anything where you still have to come up, because for some people, believe it or not, $30 for a copay they don't have it. They don't even have $30. And they don't go to the doctor when their kids need it because they don't have $30, right? So even a $30 copay is too much for a lot of people in this country. So this is the end. I know it's a lot, and I know it's a lot, you know, going into the weeds. I'm happy to answer any questions that people have. This is the kind of summary to you know, the main things to take away. We're too expensive and inefficient. Prices are rising way too high. It would save us a lot of money and save our country money. We believe private health insurance is fundamentally a problem and should be phased out. And it's politically popular. It's just not popular with the big donors from the insurance companies. So that's it. And I'll know there's a lot of stuff in the chat that I couldn't keep up with. So
That's okay. I'm monitoring it. Thank you, Eli. That was incredibly informative. We have a bunch of questions in chat, as you can see. And I think what I'm going to try to do is try to pick out the ones about coverage for, like, Lynn wants to know, are all prescriptions included in Medicare for all? And somebody else asked about mental health care.
okay, so what's the first one?
The first is about prescriptions,
yes.
and the second is about mental health care.
Okay, so for the prescriptions, again, what's covered by Medicare now would continue to be covered. And, you know, the bill doesn't get a lot more, like there aren't, you know, like formularies and stuff like included in that. The expectation is Congress would then, you know, or the whoever is the administrator of Medicare, who is chosen by whoever's president, and this is an objection that some people have that is a fair one to debate, you know, that we might get a president down the line who hates it and tries to destroy it. But the reality is whoever is president, you know, is in charge of putting people in charge of Medicare, and Medicare would determine that. The second question was about mental health care. I mean,
Yeah.
again, it's the same thing. You know, if it's covered by Medicare, it will be covered under Medicare for all.
Okay. More questions about costs. First of all, costs with the current system. So what factors caused deductibles to skyrocket in 2008 and premiums? Why did that happen? And would we expect that to continue?
We can expect it to continue, and in part, it just simply has to do with the fact that you know, people have found ways to make money, you know, in healthcare. It's things like you saw with insurance companies. It's also things like that you've seen with, you know, the price of insulin being bought, and then the price being jacked way up because they know that they have a you know, a captive market. If you've got diabetes, you've got to pay insulin. You know, if you raise it from $30 you know, a vial to $600 a vial, then people are going to stop spending money on anything else, and they will spend the $600, and you can get that much out of people. I think probably that, you know, I hate to say this, but I do think that Obamacare contributed to some degree to this. Now, what I think happened is that Obamacare was passed, and then it was immediately sabotaged over and over and over again by Republicans. frankly, and and so removing the individual mandate, weakening, all kinds of requirements for that were built into the law. What that did was the insurance companies said, well, if you're going to stick us with this requirement that we have to cover people with pre-existing conditions, that's going to cost us a lot of money. People with pre-existing conditions are expensive, especially people who have, had cancer and they're going to get cancer again and so on. So we're going to make up that money elsewhere, and we're going to just start charging people more money. Then you get into this bad circle, this downward circle where people lose their insurance, or companies just stop carrying it. So now there's less money in the pool, right?
Right.
So when there's less money in the pool, then everyone has to pay more. And the argument for having all 330 million of us in the pool is that that's a lot, that's a much bigger pool.
Yeah.
Yeah.
Okay. Let's see. Let me see what some other questions are here. Did you see one?
Oh, sorry. Go ahead. You go ahead. I was
Okay. All
going
right.
to fill in. But.
What about health outcomes? What do we know about the impact of Medicare for all, or expected impact of Medicare for all on health outcomes?
Well, I mean, I go back to the comparison with other OECD countries. Health outcomes are a complicated thing. It's not just health insurance. There are other things that play into it. In general, when you have a very poorly built, in my opinion, safe social safety net, so poor, public education, poor public health in general, you get bad outcomes, but this plays into it. So I want to be careful not to like overpromise and say that if we get Medicare for all, our maternal mortality rate, our infant mortality rate, our obesity rate, our life expectancy, all those things will fix themselves and suddenly we'll look like Japan or New Zealand, right? That's probably not going to happen quite like that, but it absolutely would help health outcomes, because what happens, as you guys probably know, is that if you don't have insurance, or if you have insurance with copays and deductibles that you can't afford, you delay and delay and delay going to the doctor. When you have a cough that doesn't go away, when you have a lump, when you have a chronic pain, that doesn't get better on its own with ibuprofen, and by the time you go, it's too late, and now some kind of super expensive invasive surgery, chemo, all this stuff has to be mobilized, and it's often too late by then. Or if you do survive whatever's wrong with you, you've got chronic problems. So it's not just the health outcomes, it also is more expensive that way, right? They always say an ounce of prevention is worth a pound of cure.
Or even if it's not too late, you can't afford the treatment.
Right.
The treatment
Right.
bankrupts you. Yeah.
Yes, absolutely. People are very much in favor of that. And that survey comes from before the pandemic. There was one done in the summer that showed similar numbers, even but with the caveat of, even if you had to give up your private health insurance or your employer sponsored health insurance.
And people still said overwhelmingly yes.
Yes.
Yeah. So some people are asking about costs. More reason the estimate of how to cover, like will the enhanced Medicare offerings not cost more than the current 1.9 currently being paid by Medicare and other single payer systems, using your estimate? Then somebody adds, Vermont tried its own state insurance for all, but it failed due to very high costs. What can you say about that?
So yeah, the Vermont thing, it didn't fail. They just never tried it. They passed it as a legislature, and then the governor chickened out, and it goes to show the difficulty of doing it at the state level, which is why I haven't talked about the Yusuf Rabi bill. I think it can still be done, and a lot of lessons can be taken from Vermont, but the I guess part of the problem, with Vermont was the sticker shock of what the tax increase on individual households and on employers would be, and there wasn't, a clear sense that that Vermont, a small state, would be able on its own to raise the kind um, of revenue necessary to replace the loss of the private health insurance.
Uh-huh.
So and there's a big fundamental difference between the federal U.S. government and state governments,
Mm.
and that is that state governments cannot go into debt, whereas the U.S. government actually prints money. And I know that's controversial too for some people to say, because they'll say you can't just keep printing money. But we've done it over the last year, and Joe Biden is planning on printing another $3 trillion in money. Like that $3 trillion rescue package that he's seriously talking about doing as soon as he takes the oath of office, basically in whatever it is, 5 days or 6 days from now. That's not being like funded by raising taxes. They're just going to go into debt for that. And the
Mhm.
US government can continue to do that. And so that's where states, especially small states, run into problems. Bigger states like New York State and California actually, I think, can do this. They have a big enough budget to do it. I just think that really small states like Vermont is very difficult to do.
Mhm. Okay. And what about the broader question about if we're including if we're including all of the mental health care, behavioral health care, the dental and vision and auditory health care, is that not going to make it so like overwhelming, staggeringly expensive, more so than what we're currently paying? I mean, you said
No,
6 trillion is what we're
it's what
paying
we're
now,
heading. It's what we're heading
where
to.
we're heading, and 3 trillion is where we are.
It's a little bit over. It's like 3.1 trillion now. Yeah. I mean, that 3.1 trillion includes every dental visit, every
Includes
eye
all that.
doctor visit, every hearing aid that gets purchased, whether it
Okay.
gets purchased just out of pocket, whether it gets purchased from a Medicare Advantage plan, whether it gets purchased from an employer-sponsored healthcare plan. You know, took my kid to the dentist the other day, and the other kid to the orthodontist, and Blue Cross Blue Shield paid for that. I
Mm-hmm.
mean, technically, the people who paid part of their salaries into Blue Cross Blue Shield then paid for my kid's braces,
Yeah.
and
Yeah.
my other kid to get his dental checkup. But that's still money that got spent. Now, in this
Got it.
system, it's the orthodontist and the dentist will get about the same amount of money. Now, it is true that some of the private health insurance plans, they reimburse more, and that's why dentists and orthodontists don't take Medicare. That's why it's not offered. And so there are probably some dentists and orthodontists who might end up making less money. But we're not talking about going out of business. We're talking about, one less ski vacation in Vail or something like that.
Maybe one less home in Vail. Um, just a heads up that a Facebook watcher says that the 70% number comes from a 2019 Reuters poll.
Okay, I think it's
Okay.
KFF. KFF
Also,
did a different poll, but yeah.
okay. Also from Facebook, how do we get unions to get over how much they've given up in wages for healthcare? That's an interesting question.
Yeah, this is a really,
Right.
really important question. And this
Yeah.
is one that Jayapal and Sanders, in our opinion, have not yet adequately done a good enough job of addressing. And that we have pressed, one of the other big advocates for this is Debbie Dingell, who is the representative for the district here in Ann Arbor,
Mhm.
Ypsilanti. She's brought this up many times, and she's talked to Jayapal, and we've talked to her and Jayapal, and we've talked to her and Sanders, and it's an issue. I mean, it really is an issue. People have a legitimate complaint here. They gave up, as I do as part of a union. I've given up wages for healthcare to stave off even worse healthcare deals.
Mhm.
And there are people who've worked their whole lives with GM or Ford or whatever the case may be. And, they've probably given up hundreds of thousands of dollars of salary
Right.
in order to get a good healthcare deal, which in the end was worth it, I'm sure, for themselves and their families. It gave them peace of mind, and it probably saved somebody's life along the way in their family. So we believe that um, there needs to be some kind of retroactive compensation for that, for people who had union plans in which they could demonstrate that they gave up lifetime earnings for their health care. And it needs to be retroactive. Now, I will tell you that when we talk to unions or union members, what we find is that the older members, the retired members, they're the ones that bring up this concern. The younger members who are, just starting their work, their work careers, they're in their 30s or 40s or 20s, they don't mind. They've been part of these negotiations too, but they say they hate it so much. And this is how I feel, somebody in their 40s, and say, like, you know what, I don't care, whatever it is, 40,000, 50,000, 60,000, whatever it is that I've lost, it's water under the bridge. Forget it. I never want to have to go through this again, where they say, do you want to raise, or do you want your premiums to go up another $500?
Yeah, right. We're almost out of time. We really are out of time, but I want to ask you to respond to this one question. I'm sorry we haven't been able to get to every question, but I wanted to, somebody says fraud, waste, and abuse are a huge problem for Medicare currently, about 10%. How will that be addressed on a larger scale in Medicare for All?
So that's not the number that I've seen. I've seen it's actually lower than that. It's more like 4 or 5%. I'd be interested in the person's source, because there's conflicting reports about that.
Yeah.
Yeah, I mean, there's always, in any sort of program like this, there's going to be some fraud, waste, and abuse. But number one, the global budgeting will take care of some of it,
Mhm.
right? Because whether it's a like a practice, or like a joint practice, or whether it's a urgent care clinic, or whether it's a big hospital like Beaumont or Bronson, or Michigan Medicine, you know, they will have to think carefully about what they are going to be billing Medicare for. It's not just Santa Claus every single day. Whatever you get, whatever you want, you get. You can bill, $50,000 for one MRI. The government might send that to you, but you might be $50,000 short at the end of the budget period. And that's going to have to come out of your Vail ski vacation or whatever. Like, you know what I mean? Like you have to really sit down and be like, okay, we have to make this $200-300 million stretch. And so, if we, so you get the point. And honestly, there's fraud, waste, and abuse now. But way that the private health insurance companies deal with providers who overbill them or bilk them, is to just go through every fifth claim and reject it.
Yeah.
Right.
Mhm.
So the people who are bilking Blue Cross Blue Shield get away with it. And then the poor person who has chemo or radiation gets a bill for $85,000 in the mail to make up for the person who's bilking it. Like, there's just as much waste, if not more, in the private health insurance, because they don't really care about fairness. They're just, all they care about is that bottom line at the end of the fiscal year and how their profits are looking.
Yeah. Okay. All right. I wish we could, I'm looking at other wonderful questions. Everybody, apologies. We can't get to all the questions. Eli, thank you so much. This was incredibly interesting, enraging, informative, heartbreaking, necessary. Thank you so much. We really appreciate your time.
Teresa, I'm putting my email in the chat. And
Great.
for folks who didn't get their questions answered, I'm happy to email, talk on the phone, anything that people want to talk more about.
Fantastic.
I'm not usually on Facebook that much anymore, but I'm happy to, exchange emails, or to just talk on the phone, or do a one-on-one Zoom conversation. So
Wonderful.
I'm putting that in the chat. Grab it if you want to talk more.
Great. And we can make your PowerPoints available to for people who are interested as well.
Yep.
Thank you very much. Thank you all for being here. Thank you to the great tech team. Take good care, everybody. Stay well.